Hey there, this is Dr. Andrews, and we're here with another one of our podcasts. And today we're going to talk about a procedure. It's kind of a sensitive topic. Whenever we talk about a woman's breasts, there can be a lot of emotion associated with this. We get into this with patients who have breast cancer, so with breast reconstruction. We get into this with patients who come to see us with small breasts, breast augmentation, and we also deal with these issues when patients come to see us when they have large breasts, breast reduction. Women, if you talk to them, many feel that their breast size and shape affects their sense of femininity, their body image. And it's an anatomic or it's a part of their body that helps determine their female identity. This can be a very, like I say, emotionally charged topic. We're here to help because women who have breast cancer and are faced with potentially losing their breasts, women who have small breasts, who feel they don't really have that feminine shape and size and physique that they want, and women with large breasts who both can be embarrassed by the size of their breasts, because sometimes women develop large breasts around puberty, but also have functional issues when their breasts are large, meaning the large breasts can cause neck pain, back pain, and for the neck and back pain, patients are prescribed medications. They see chiropractors. They go to physical therapists. Many of them have really bad posture, and they kind of walk hunched over because the breasts are heavy. And one thing people don't realize is that breast tissue itself, and not necessarily fat, but breast tissue is fluid filled, and fluid is heavy. And the fluid filled breast tissue, the fibrous, dense breast tissue, weighs more than fat. And so when women, especially young women of childbearing age before menopause, these breasts can be remarkably heavy. Like I say, affect a woman's ability to work out, to be active, and so it can be quite distressing. The other thing is when your breasts are large, they're long, and so there's a lot of contact between the posterior surface of the breast and the chest wall and actually the abdominal wall, because sometimes these breasts come all the way down to their abdominal skin, and they can be troubled with something called intertrigo. And that's where two skin surfaces abut. Those areas are dark, they're warm, and they're moist. And fungus, unfortunately, likes to grow in that environment. Women can develop this intertriginous candidiasis, this candida that develops there, and have to use drying powders, antifungal medications, and sometimes they get excoriation of the skin, like these skin ulcers. Large breasts not only can be, or having large breasts not only can be embarrassing for women, but there can also be functional issues. Luckily, there is a procedure that can help address these concerns. And it's what we call a breast reduction or mammoplasty reduction. With that procedure, we remove the excess skin, we move the nipple up to a higher location, so that's what makes the breast quote unquote perkier, but we also remove the excess breast tissue. The first two things, removing the excess skin and moving the nipple up, are essentially what we do when we do a mastopexy or a lift. And so a lot of women ask when they come in for a breast reduction whether their breasts will be higher, tighter, and will they get a lift. Yes. The answer is a resounding yes, because built into every breast reduction is a mastopexy, is a lift. And so their breasts will look more youthful, sit higher on their chest. And then the last thing we do, of course, is remove the excess breast tissue. And that's the functional component of the procedure. Because there is a functional component to the procedure, many times the procedure is covered by insurance. Now, with that being said, sometimes that hurdle is quite high. And previously, that hurdle was even higher. So a landmark study was published by a plastic surgeon named Schnur. And what Schnur did is he did a regression and determined that for a particular woman of a particular size, meaning he produced something called a BSA, a body surface area, which is a ratio of your height to your weight. Based on a woman's body surface area, if you remove a threshold amount of tissue for that particular woman, again, with a particular BSA, there was symptomatic improvement. And so the diagnosis that is covered by the insurance company is something called symptomatic macromastia, meaning large breasts that cause a functional issue. And in this case, neck and back pain, grooving in the shoulders from the bra straps, rashes, postural issues, trouble finding bras that fit, trouble being active, trouble working out. So the moral to the story is if you have large breasts and you have symptoms associated with having large breasts, number one, there is a solution. Number two, the procedure sometimes can be covered by insurance. And even if it's not, you can pay out of pocket. Most plastic surgeons offer some type of financing to cover that. And so we can get you through this and get you to your goals. So if you come to see us, you'll come in for what we call a consult. And oftentimes your insurance company will pay for that consult. So what we do when you come in is we talk to you about the symptoms that you have. It is good to have what we call a paper trail, right? And so it's important because some insurance companies do require that you have documentation that you've had mitigation strategies to address your symptoms, meaning you've been in physical therapy, you've been in chiropractic care, you have taken anti-inflammatories, you have gotten special bras, and those things have been ineffective, essentially, to manage the issue, and then it bumps up to needing surgery, right? So you have been under the care of your primary provider. Some insurance companies require that you have documentation that that's been in place for 3 months. Some have that it's been in place for 6 months. So it's good to have that documentation. It's not absolutely essential, but it's absolutely good to have that. So if you do go to a consult, you come to see us, if you could have that, that'd be nice, especially if you've been prescribed antifungals for rashes and things like that. Then what we do is you assess your candidacy for surgery, talk to you about your medical history, and then we take measurements of your breasts. And this helps us with our planning, and it helps us determine the type of procedure that you would need, because there are different ways of doing the procedure, and we're going to talk a little about that later. And so we take the measurements, and we also get pictures, because the insurance companies, like I kind of joke, I say the insurance companies are from Missouri, the show me state, because sometimes they don't just take our word for it. They actually want to see the pictures. So we do get pictures because that's part of the medical record. And again, sometimes insurance companies ask for it. And then in our practice, we will do something for you called a simulation, which is actually really cool. And so we'll use Photoshop to show you what you can look like with the procedure. And it's quite instructive when you see that, to see what's achievable. So after the consult, we will put this through your insurance for pre-authorization. And so how does that pre-authorization process work? Well, what happens is that the plastic surgeon has to predict how much tissue they think they can remove. And if that amount in grams is above the threshold for your particular BSA and that little nomogram that your insurance company provides us, then it is covered and it's considered medically necessary. And so that process, after the dictation is done and that number is stated and your other symptomatology is discussed in the charting, that's sent to your insurance company. It can take 5 days, sometimes 2 weeks, depending on the insurance company, to give us an approval. And those approvals last for about 90 days. And so that's important to know. So if you say, I was approved by my surgeon last year, can you schedule me for surgery? Unfortunately, that we can't if you come to see a new doctor, because it has to be under that particular doctor and it has to be within 90 days. We have to ask for that approval and do the procedure within a 90-day period. I had an interesting experience with a patient, and she gave us permission to show her pictures. And we'll show you this. This is a woman who had she had a lift, the same incision pattern that you have when you have a breast reduction, but I was just doing it. Actually, I put implants in her and a lift, but the same incision pattern for breast reduction. And 4 weeks after surgery, she went out and a friend of hers gave her a big bear hug and lifted her up. And she called me that night. This is literally 4 weeks after surgery. And she was in the emergency department saying, I'm in the emergency department because my wound opened up. She told me the story. And I said, leave the emergency department. I'll see you tomorrow. I met her in the office on a Sunday. I had one of my staff members come in. We had to wash things out and reclose it. She's healed now. She's totally healed. But it is very instructive, because what you see in the picture is a healed incision here, a healed incision here, and an incision that has, the word is dehisced or opened here, which goes to show, even though it looks like it's healed, it's healing. And that process can take up to 6 to 8 weeks to be solid. There's a spectrum, right? The day of surgery, we sew it together, it's healing. It's a little bit healed. The next day, it's a little bit healed. It's more healed. It's healed more. The next day, it's healed more. Next day, it's healed more. Next day, it's healed more. It's not ready for the SNL prime time. It's not ready for prime time. It's not ready for a bear hug, probably for 2 months. 2 months, you can get your bear hug, but not at 1 month, as was demonstrated here. So there is a recovery period. So it's very important to understand. And it is a patient dissatisfier when they have a problem. So I said patients do 2 things. Number one, they say, it's not going to happen to me because of my prior experience with surgery, not in body contouring surgery. Now, the second thing they do, which is sometimes more emotionally charged, is they don't understand how much a complication, meaning a wound separation, affects their life and their psyche, right? Because people have some hormonal neurotransmitter changes when they have surgery. That's known. You get cortisol, you get all sorts of, because it's trauma. People don't think of it like that, but it's trauma to your body, and your body has all these hormonal changes that occur, and their affect becomes labile, right? They become more emotional. Some of the medications make them more emotional. When they see their incision open and they see some tissue that is unhealthy, that bacteria is growing on and producing gas that makes it smell, they have this impending sense of doom that something terrible is going to happen to them over the next couple of days. And I've had even doctors tell me this, right? I had a doctor one time had surgery and had a little wound issue and almost was in tears. And I said, what is it? And because she was a doctor and I'm a doctor, we had this little interaction, this relationship. And I said, what are you thinking is going to happen? She says, well, I take care of patients who are in the ICU. And I know patients develop systemic infections and this and that. And I'm wondering, is that going to happen to me? Right? So that's very important that we try to prevent complications, because people don't understand the effect that complications have. And there's some things that we'll talk about to help decrease the risk of complications. So you come in for your consult, we do your pre-authorization, and you have the surgery. What happens during the surgery? We mark you that morning. In my practice, we do something called a block, genius procedure. What we do is we find the nerves that travel to your breast and we bathe them in a long-acting local anesthetic. And this is a very advanced procedure, and you have to have an anesthesiologist who knows how to do blocks. And it wasn't until, the last 10, 15 years that almost all anesthesiologists, traditionally the anesthesiologists who would do what's called a fellowship, a pain fellowship, or a regional anesthesia fellowship, would know how to do these blocks. Not all anesthesiologists knew how to do it, but now most of them have learned how to do it, because it requires ultrasound, and you have to understand ultrasound anatomy. And so basically what we do is we find the nerves that travel to the breast that travel in planes, and that's why they're called PLANE blocks, plane blocks. And there's a ESP block, erector spinae plane block. There is a pectoralis 1 and 2, or serratus anterior plane block. And so basically, you're finding the planes that the nerve travel in, and then they bathe them in a long-acting local anesthetic. And the local anesthetic that we use is something called Exparel, which is genius how it works. It's a marvel of chemical engineering. Essentially, it is the long-acting local anesthetic in these fat spheres. When they're injected, the fat dissolves over time, over 72 hours, and the anesthetic that's trapped in those spheres is eluted into the tissues, and it works sort of like a sustained release pill that you take, that you only have to take once a day because it has a special coating, and that coating breaks down over time in your GI tract and it's released. So it's a genius medication called Exparel, and there's some facilities that number one, there's some facilities that do blocks, and and even fewer who do blocks with Exparel. So if you have it done, ask if Exparel is used, because it can prevent you from needing any narcotic during the procedure, after the procedure. I'm not saying you're not going to have no pain, and you're going to have any pain, but hopefully Tylenol Motrin will be sufficient. So we do the block, we give you antibiotics, and we will give you some antibiotics to take after the procedure, and then we do the procedure. And like I say, the procedure is pretty extensive. To do it right, and if you have a large breast, sometimes it can take 3 hours, 4 hours. Sometimes you can do them in 2 hours if you have a lot of help. But one thing I tell patients and their families, don't rush your plastic surgeon. Probably not a good idea. Of course, we want to work expediently, but we don't want to feel rushed, and we don't want to rush because, after you're healed, it becomes about cosmesis. It becomes about where your nipples are. It becomes like how much excess skin do you have? Is there symmetry and that sort of thing? And so it does take time to produce these things. And again, you got to remember, we have to do it twice, right? So we have to literally do 2 separate procedures. We do one on the right, we do one on the left. And so these procedures can take some time. After the procedure, if you're in our practice, we'll put something on called an incisional wound vac. So we use this incisional wound vac. There is a concept called closed incision negative pressure. And essentially what we're doing is we're shrink wrapping or vacuum sealing your closed incision. Traditionally, wound vacs are used for open wounds, but the concept of using foam, a sticky drape like a sticky saran wrap, and putting that construct to 125 millimeters of suction pressure to shrink wrap that dressing on an open wound, and now on a closed incision. And we've been doing this for probably the last 10 years. Plastic surgeons were sort of innovative in saying, how do we mitigate movement of our incisions that are closed under tension, right? How do we splint our high risk incisions, right? Now, there is a cost associated with, and most orthopedic surgeons or cardiac surgeons or plastic surgeons who use these devices use them sparingly. They don't put them on everyone, but they'll tend to put these closed incision devices on high risk incisions. And so 3M, KCI, who makes the wound vac, there are some other companies, but they were first to market, who make these wound vacs, developed a specific wound vac for a closed incision. It's called the Prevena system. And now they have all these innovative dressings that are peel and stick for different indications. So they have ones for patients who have heart surgery, and they'll put it right on their sternum to help prevent sternal wound dehiscence. They have ones that are specifically shaped for an incision for someone who has a knee replacement, right? And they put that on there. Patient has an elevated BMI, smoker, diabetic, has increased risk of that wound coming apart. They'll put one on there. There's one developed for the breast, and that's the Bellaform, the Restore. It actually is a remarkable device. And so basically, peel the backing off, put it on the breast, peel the backing off, put it on the breast. We have this Y connector that goes to this tube that goes to this pump that's portable. So it's specifically meant for outpatient use because we have these big wound vacs that are used for the hospital, but a small compact device that goes into a little pouch. And what is it doing? This is the concept. You splint the broken bone. You cast the broken bone. Can we do the same for a closed breast incision? So basically what it's doing is it is vacuum sealing, shrink wrapping your breast so that when you move, it moves as one unit, opposed to you move, this breast is going here, this breast is going here, and constantly stressing those incisions that we just sewed up, it shrink wraps things. And so it moves as one unit. And it's been a revolution. There are numerous studies that show that closed incision wound therapy decreases infection and wound dehiscence rates or wound separation rates in all types of surgery. I mentioned heart, orthopedic surgery, vascular surgery. There are many studies that show that closed incision negative pressure wound therapy helps for breast procedures, breast reconstruction namely, right? Where those are very high-risk patients who've had chemotherapy and radiation and have mastectomy flaps where you undermine tissue, cut through blood vessels, decrease oxygen delivery to tissues. There are also studies, and we will link this to our website if you want to see it, a study that showed that in breast reduction patients, when you use closed incision, negative pressure wound therapy, fewer infection rates, fewer wound dehiscence rates. And so we use that in our practice. And if you have your procedure done elsewhere, ask them if they can use it. Sometimes the hurdle is whether the insurance is going to pay for it. But sometimes they can get insurance to pay for it. But it's something also that if you want, you can pay for it and ask your surgeon to put it on and say you'll pay out of pocket. And they could literally put it on you the next day. Say they do your procedure at the surgery center or at a hospital. You could come back to their office the next day, and if they have one, they can put it on. It doesn't break the bank. It's hundreds of dollars, not thousands of dollars to do. And the pump lasts for 2 weeks. Again, the critical portion of your wound healing. So we'll put that on at the time of the procedure. We'll give you some antibiotics to take home. We'll give you some pain medicine. Drains. A lot of people ask about drains. This is the problem. When we do these breast reduction procedures, we're undermining tissue and we're creating a lot of what we call dead space. And based on pressures, and this is just fluid dynamics, this is high school chemistry in a sense, right? Where you have an area of low pressure and you have a semi-permeable membrane, right? Like the capillary, right? And you have higher pressure inside the blood vessel. Fluid will go through that membrane into the area of low pressure to try to equalize the pressure, which is why wherever you have space in your body, whether it's in the breast, in the abdomen after a tummy tuck, or in the thigh after a thigh lift, if you have an open space, your body fills it with fluid, and that's called a seroma. And so that's why we use drains. It does two things. Number one, it sucks the tissue back down to eliminate that dead space, right? Sucks the tissue down, but it also sucks out the fluid that's produced, right? And so I've gone back to, in certain patients, putting in drains because it's pay me now or pay me later. Because what happens is someone develops a seroma, They have a wound dehiscence. They're not happy. Their husband's not happy. Their daughter who's taking care of them and packing their wound is not happy. If it's something that we can prevent, like an insurance policy, let's do that. After the 4 weeks, most patients are happy. As a matter of fact, breast reduction in terms of statistics is increasing almost every year, especially after COVID. Patients had a little bit more downtime, and we really saw the last year we have statistics is for 2022. There were about 136,000 breast reductions that were performed. This is ASPS data, the American Society of Plastic Surgeons, and that grew year over year. Breast reduction is a highly sought after procedure. It's popular in a plastic surgeon's practice. As a matter of fact, it's one of the number one procedures. I remember when I was at Kaiser Hospital in Oregon. I did a rotation at Clackamas Kaiser. It was the most common procedure that was done. It's an HMO, and it was a covered benefit. And actually, it was interesting there is that they required every patient to go, because it was covered and because they did so many, their PA there would do a seminar. They would do a seminar, such as what I'm doing now, this sort of education process, and they required it. If you wanted a breast reduction, you had to go to the seminar. And they were very frank. They would show large breasts. They would talk about drains. They would talk about wound dehiscence. They would show pictures of patients who had wound dehiscence or delayed wound healing. I don't know if it was kind of a scared straight sort of situation to show patients, what you could, potentially get into. They talked about the BMI requirements. That's something I haven't discussed. Some insurance companies have a BMI restriction. It's been shown that patients who have an elevated BMI have an increased risk of complications. And as a matter of fact, there was a recent study, and we're happy to provide it for you. And as a matter of fact, I have it laminated in my rooms, and I read this data to patients. But patients who have an elevated BMI have longer operative times, require larger resections, and have a greater risk for wound healing, requiring greater than 2 months to fully heal. What I do in my practice is I don't allow patients to suffer for months with open wounds. What I like to do is we clean them up with dressing changes, we debride them, we do some dressing changes, and I'll reclose them, right? And patients really, really like that. And so sometimes it comes apart again, right? Because the same forces, are working on it, and you're operating on the same patient. But many times we can get them fully closed quicker than allowing the wound to heal by what's called secondary intention. But I mention this to say some insurance companies and some plastic surgeons have a BMI restriction because it is linear with almost every procedure that we do in surgery. There is a linear increase in complications. And for breast reconstruction, it was 7% per BMI point, meaning a BMI of 30 versus a BMI of 29 increase your risk of complications 6 or 7%. So every increase, 31 is worse than 30, 32 is worse than 31, and so on, right? And so elevated BMI increases the risk of complications, and not just wound dehiscence, every complication, infection, hematoma, which is a collection of blood, seroma, collection of fluid, wound dehiscence, soft tissue loss, nipple issues, right? Nipple viability issues. I do want to mention that too. Patients ask about whether you can breastfeed after the procedure and whether the nipple will be functional, meaning whether the nipple will be sensate, will there be arousal erections. I will say, with respect to breastfeeding, you should be able to breastfeed. Many studies and many patients have had the experience that they can breastfeed after the procedure. We can't guarantee that you could fully support your baby. You might have to do some formula, some breastfeeding, but you should be able to breastfeed. With respect to nipple sensation, this is what I say. Your nipple sensation is here. Sometimes it becomes hypersensitive. Your nipples, you hug somebody and it's hypersensitive. That typically almost always goes back to your baseline. If your nipple sensation dips down, what we say, if it's not back after 18 months, nerves grow an inch a month. So it takes time. If those nerves are separated during the procedure, which of course nerves are separated with every procedure. I don't care if you just cut your finger, you're going to cut through some nerves. If when those nerves are separated, they have to grow back. It can take time. It can take months, a year, sometimes a year and a half to fully grow back. If your nipple sensation is not back after about 18 months, probably not coming back. So if that's a concern for you, it's a real concern. And I've had a number of patients where it is an absolute concern, and any risk of decreasing nipple sensation is a no-go, then you probably don't want a breast reduction. So let's draw this out. So what we're showing here are the two incision patterns for a breast reduction, breast lift, any procedure where you need to remove skin and move a nipple. You have to make your incisions in a certain pattern, and you have to move your nipple attached to tissue. There is something called a free nipple graft, and all of this stuff goes out of the window when you do a free nipple graft, because you essentially can put the nipple anywhere you want. It's something that we do in transgender surgery, quite frankly. The problem with the free nipple graft procedure, which I've done them, which I don't like, because a free nipple graft means that you're taking the nipple off, and we have patients come in, you're going to take my nipple off. We actually don't take the nipple off. You can. I don't like to do it. Some plastic surgeons do it with impunity. The problem with doing it is it makes your nipple a cosmetic nipple only. There's no function, right? You lose all sensation, pretty much. You'll have maybe protective sensation, but you won't have functional sensation. Your nipples typically won't become erect again. You can't breastfeed, right? No breastfeeding. And your nipple will flatten and your areola can depigment. And that's a big issue for African Americans. So when I was in my first practice back in Illinois, we had a fairly large African American population, and I was doing these free nipple graft procedures on these, gigantomastia patients. Gigantomastia, where we remove over a kilogram, over 1,000 grams of tissue. They were a lot of them I would do. I was at a residency. I was risk averse. I didn't want any problems with nipples dying, and so I would do what's called a free nipple graft. They would depigment, right? And 3-4 months after surgery, when they didn't have pigmentation, they looked like they had vitiligo, in their areola. They weren't happy. And so that's the issue with the free nipple graft. But so wise pattern, vertical incision. Okay, so let's talk about what happens here. So I will say, we'll just arbitrarily call that A, we'll arbitrarily call this B, and we'll arbitrarily call that C. So essentially what's happening here is that you have a nipple that's lower than it should be. You can carry that nipple on what's called a pedicle. That pedicle, meaning you have to keep the nipple attached to some tissue to provide blood flow and the lobules and ducts to make milk. And in this scenario, we are using what's called an inferior pedicle. Okay? So what happens here is we elevate this triangle as what we call a flap, and it's about 2 centimeters in thickness. And then we elevate this triangle 2 centimeters in thickness. So there's an incision that goes all the way around there. And inside the pattern, all of the skin is removed except the skin of the nipple and areola. And a lot of people ask, I've seen areola this big, right? The brown part this big. We make it about 4 centimeters. That's what's standard. 38 up to 5 centimeters, or 38 millimeters, 50 millimeters. So we do make your areola smaller. So we talked about the inferior pedicle. We can also have what's called a superior pedicle. That's where the nipple is being moved to the higher location. The nipple's always moved up. It's never moved down, always moved up. You can keep it attached to a tongue of tissue from the top of the breast. And then all of this tissue is removed, right? There's another pedicle called the superomedial pedicle, where it's based on a pedicle, some superior, some medial. Sometimes that allows us to swing it. It gives us more degrees of freedom to swing the nipple. So again, I'll reiterate. We have to remove the excess skin with a incision pattern. We elevate, and we remove the excess tissue after we elevate. The skin flaps off of the excess tissue. And we also have to move the nipple on a pedicle, right? So let's think about this. Say we do an inferior pedicle. What happens at the end of the procedure? At the end of the procedure, this is what you see. Okay, you have your pedicle, and that's infantum, right? Because the pedicle is buried under these flaps. So what you're doing is you're stretching that down to here, and you're stretching that down to here. And I emphasize that for a reason, because this is what produces the lift. This is what produces the tension that occurs when we close these incisions, because there's a distance between here. And to make up that distance, we had to elevate this tissue so that we could move it. We had to elevate this tissue so that we could move it. As a matter of fact, we elevate all the way up to the clavicle. We elevate this all the way up to the collarbone. And we elevate this all the way up to the collarbone at a thickness of about 2 centimeters. And then we pull it down. And we sew it here. This is called the T-junction. That's why we say it's an inverted T, or it looks like an anchor when you think of the nipple, right? Remember, what we do at the top of the pattern, when we close this, what we do is we make an incision here, the diameter of our new nipple and areola, and we sew our nipple into that area, right? And that's how we bring that out. But the rest of the pedicle is buried under the flaps. The problem with this is we have that T-junction here. We call this the T-junction. And the problem with the T-junction is, remember, this is a triangle that came from here. This triangle, right? So this was sewn to this, and this was sewn to here, and this was sewn to here, right? The problem is, if I'm a cell that lives here, I used to be able to get blood flow from here, I used to be able to get blood flow from here, and I used to be able to get blood flow from here. Now I can't. Now I only get blood flow from here. And what happens is, because of decreased blood flow to this area and tension, sometimes these little triangles die, and you get an open area here, right? You'll get an open wound here at the T-junction. And that's the area where, if you have a seroma and the fluid comes through, typically comes through at the T-junction. If you have wound dehiscence, wound separation, typically happens at the T-junction. If you have some soft tissue necrosis of your flaps, right, of your breast flaps, happens at the T-junction, which is why a lot of plastic surgeons went to this pattern, right? Let's eliminate this T-junction, okay, to improve healing for patients. So in this procedure, what we do is we remove tissue in this pattern. So our nipple's here. In this pattern, we almost exclusively use either a superior pedicle
or a superomedial pedicle, right? So that swings up here. This is made, right, the diameter of the new areola, right? So we're able, so this procedure, again, the reason this procedure stood the test of time, because it does two things that are very important. It narrows the breast with this removal, and it shortens the breast with this removal. Okay? Narrows the large breast, shortens the large breast, requires a vertical takeout to narrow and a horizontal takeout to shorten. So it does exactly what we want it to do, and it moves the nipple. Okay? The problem, or the tough thing with this is if you have a long breast, you're not specifically addressing the length of the breast. You're addressing the width of the breast with our vertical takeout, but not the length of the breast. And that's what, right? Remember, that's one of the reasons we come in when we have a saggy breast, is you want it shorter. But I say sometimes in plastic surgery, there's no free lunch. So what happens at the end of this? Well, we elevate, we remove tissue, keep this attached here. And at the end, you could say this is A and this is B, right? At the end, what you're left with is this. A, B, there, all that sewn up, right? And you're avoiding this. The problem with this is, like I say, there's no free lunch. Sometimes you're left with excess tissue at the bottom. Now, a plastic surgeon named Frank Lista developed a procedure where you do these things called boxing sutures, which is kind of interesting. So you take a bite here, you take a bite here, you take a bite here, take a bite here, and you take a bite here. And when you do that, you sew that up. Not only do you sew it together, right, because the suture comes like that, not only do you sew this together, but you actually hitch that up. And you're able to remove some of that vertical excess. Bottom line is, to do a breast reduction, you have to remove skin, so you need an incision pattern. To do a breast reduction, you have to move the nipple up, so you need a pedicle to carry the nipple on. And you can be left with a lollipop, or you can be left with the inverted T or anchor scar. I like this procedure for most of our patients. Pretty much all of our patients that come in who need a breast reduction need this. But again, there are some plastic surgeons that also like this. And so just wanted to describe how we do the procedure, because you will read some of these online. Thanks.
But with that being said, I've enjoyed producing this podcast for you. We are absolutely happy to see you in our practice. One of the things that we have is we're affiliated with something called Corridor Surgery Center. It's our own accredited Medicare certified facility where we can do cosmetic and insurance cases. And it's a single specialty operating room. All we do is plastics. All our anesthesiologists, when they're here, do is plastics. And I've been working with the same group for many, many years. And they take care of my plastic surgery patients. They do the blocks. All of my staff take care of plastic surgery patients every day. It's my same staff that sees you before surgery. They take care of you during surgery, and they take care of you after surgery. So there's that continuity of care. They get to know you. You become part of our family. The other thing is we do blocks down there. As I mentioned, we use a Bellaform. But the other important thing is, especially after COVID, hospitals had nursing shortages, and some hospitals still have nursing shortages, staffing shortages, not just nurses, but techs as well. We have our dedicated staff, and so we might be able to get you in sooner, because some hospitals have had to sort of, kind of ration OR slots, operating room slots because of COVID, number one, but then the staffing issues that occurred after COVID. And so we might be able to get you in a little bit sooner, because we're a single specialty OR that controls our own schedule. And we sometimes do procedures on Saturdays as well. So if you'd like to see us for a breast reduction, absolutely give us a call. 319-450-7619, 319-450-7619. And hopefully, if you don't live in the area or you go see a different surgeon in this area, hopefully this podcast has been instructive for you. Thanks for tuning in, and we'll come to you with other podcasts in the future. Thanks.